Hello everyone, good evening, and welcome to the first night and the first DEBAKEY CV Live of our annual Houston Methodist Adult Congenital Heart Awareness Week. My name is Huie Lin. I'm the director of the Adult Congenital Heart Program here at Houston Methodist, and as always, we are looking this week to educate everyone and all of our friends, colleagues, loved ones, patients, and all through the Houston Methodist community about adult congenital heart disease. Before we get started, I want to remind everybody that we want to give you the opportunity to get continuing education credit. To register, here's the link on the screen right now. You can evaluate the activity, print and download your certificate in PDF format, and go through this QR code if that helps you. The other thing we really want to make sure that you have an opportunity to do is to, if you are interested in joining us on any of these educational events, please join our Education Advisory Board. This is directed to patients and their family members, those who have congenital heart disease and those who are families of congenital heart disease. Please email one of us here on the slide. If you'd like to join us, you can participate in any of our DEBAKEY CV Lives, as well as to help us to create patient-centered education content, just like the one you're going to see today. And then finally, we have a very exciting project that is funded by the Patient-Centered Outcomes Research Institute, and we are looking specifically for adults with congenital heart disease and their family members to join our roundtable of stakeholders to initiate patient-centered outcomes research in this region. Send us an email here at scachdcollaborative@houstonmethodist.org. And without further ado, I'm going to introduce to my left the most wonderful Dr. Stephanie Fuentes, who is our third-year General Cardiology Fellow, who has had a special interest for over several years in adult congenital heart disease and electrophysiology. Stephanie, thank you for joining us tonight, and tell us about who we're going to have on the show tonight.
Thank you so much, Dr. Lin. So today we have the unique opportunity to learn from Shawn Fontenot, who is a patient and provider who was born with complex congenital heart disease, and he has undergone many of the interventions that we will learn throughout this symposium. We will also learn this information, as well as with a collaboration from CardioNerds that we have also done an CHD CardioNerds series. First, let's bring on the CardioNerds, Drs. Amit Goyal and Dan Ambinder. They are both interventional fellows and co-founders of CardioNerds educational platform. Welcome, Amit and Dan.
Wow, thank you, Stephanie. Thanks a million. We are so excited to be back at Houston Methodist and can't think of a better occasion than this special discussion where we'll get to learn from Shawn's perspective and Dr. Lin's expertise.
Yeah, thank you again so much for having us, everyone. And on this note, I have the distinct pleasure and honor of introducing Mr. Shawn Fontenot. Shawn is a pediatric cardiology nurse with 11 years of experience in ambulatory nursing, ACHD care, heart failure, transplant, ICU, and now electrophysiology. Shawn lives in Dallas with his loving wife. Shawn, welcome. Thank you so much for joining us, and thank you for sharing your story.
Thank y'all. Thanks all for the invite. I look forward to this.
And
nice to meet everybody.
And before we get started, just to make sure that we get everybody interactive and joining us, of course, as always, you can join us on all our streams, whether YouTube, Facebook, or Twitter. But more importantly, if you're interested in going through Poll Everywhere, please go to pollev, that's POLLEV.com, and enter DEBAKEY, DEBAKEY. And from there, you can send us questions throughout the entire event. Or if you're using your phone, you can join by text. Text DEBAKEY to 37607, and you can text in your message.
So let's kick things off by turning to you, Shawn. Would you be so kind as to set the stage and walk us through your journey with congenital heart disease?
Yeah, sure. So I was obviously born with this. I was born with Tetralogy Fellow with pulmonary atresia 34 years ago. My parents, it's a little bit longer ago, so there wasn't sophisticated technology like there is today. So they had no idea that anything was wrong with my heart until I was born cyanotic. So I was diagnosed, like I said, with Tetralogy Fellow pulmonary atresia. I had my first VTT shunt at 3 days old, another one at 3 years old, and then I had my Tetralogy Fellow repair at 5 years of age. And since then I've had 3 pulmonary valve replacements, a pacemaker, a biventricular ICD, endocarditis, so yeah, the whole gamut of things.
Wow, Shawn, your story really highlights the downstream implications of repaired Tetralogy Fellow on the pulmonary valve structure as well as the function. And it highlights the tools that we have in order to address this pulmonary valve dysfunction down the road. Dr. Lin, given Shawn's story, could you briefly describe the long-term vulnerabilities of the pulmonary valve after having such repair, your approach to surveillance, and some of the management considerations that you would discuss with your patients like Shawn?
Yeah, that's a really big challenge, and I have to confess in full disclosure, I don't know that we've actually completely figured it out in our field. I know that's a little bit disconcerting, but I think that also means that there's a lot of opportunity to make things a lot better. So to start with, for those of you who are not aware, Tetralogy Fellow repair initially requires an intervention on the pulmonary valve. So frequently it's too small for the child as they were born, and it's oftentimes half the size, if not smaller, than the aortic valve. And so to really enlarge the pulmonary valve in order to allow flow through it and to allow the baby to no longer be blue, they often have to do what's called a transannular patch, or in a very infrequent situation, they'll have to put in a homograft, which is cadaveric valve. Either way, after that first surgical repair, that kid is eventually going to need some sort of pulmonary valve replacement. So in the first situation where they do a traditional Tetralogy Fellow repair, it leaves the kid with wide open pulmonic insufficiency. In other words, a completely leaking pulmonic valve. And so that insults the right ventricle constantly with a volume load for the entire lifetime of that child until they get their first pulmonic valve replacement. And so you can imagine that you would probably be thinking that that kid needs a pulmonic valve replacement ASAP, right? Because you can't imagine that you were born with a valve that you don't need. It just doesn't make a whole lot of sense. But it turns out that the traditional teaching that many of our mentors grew up with is that pulmonic regurgitation is well tolerated and that kids don't really need anything done. Well, fast forward about 20, 30 years later, it turns out that's not totally true. What we find then is, just as you would suspect, that over time a volume-loaded right ventricle will eventually dilate and then potentially fail, worse exacerbated by episodes of sudden cardiac death or ventricular tachycardia, ventricular fibrillation, probably in part related not only to that volume load, but also due to the surgical scar that occurs from that initial Tetralogy Fellow surgery. It's hard to dice out which one of those is really responsible, but we do think that they're probably interrelated.
Yeah, thank you for going over that, Dr. Lin. And the saga of the pulmonary valve and repaired tetralogy really highlights and underscores the importance of a full multidisciplinary heart team, because we're thinking about potentially infectious disease experts, structural interventional experts, surgical experts, multimodality imaging experts, the CHD experts, and the entire sort of the medical team around that patient, which Shawn has gotten to know very well over the years. So Shawn, you've really been through so much over the past years, and I'm really struck by your experience with endocarditis, which, correct me if I'm wrong, but I think it was only 4 years ago now. You'd had a transcatheter malady valve implantation 5 years prior to the endocarditis event, and you had a biventricular pacemaker 11 years prior. So you certainly had a lot of prosthetic material that could be susceptible to getting infected. Could you describe how you figured out something was wrong and the toll this had on your life at the time?
Yeah, so we said endocarditis, initially first had it when I was 3 years old or so, but the second bout of it, like you said, was 4 years ago. Was doing fine, working, doing my normal thing, and then came home one day and just started feeling really run down, general malaise, just not quite right, but wasn't really sure what was going on, and just continued to feel worse that night, and horrible chills. And eventually just, no appetite, just not doing much. And just stayed like that all night, and then I actually passed out the next morning. And so my wife, told me I should call my doctor. I'm like, no, typical hard-headed husband. I'm fine. So let my doctor know what happened. So they told me to go to the ER just to make sure it wasn't an arrhythmia or anything like that, because endocarditis honestly never crossed my mind. I thought maybe it was the flu or just something else. Anyway, went to the ER, Had fever, tachycardic, like I said, horrible chills, just general malaise, and they ended up drawing blood cultures that came back positive.
So let me ask you, from what I remember, this led to another surgery. 4 years ago, you were a practicing nurse, your husband, you're well into your life, and the last thing that that you'd had done was, I think, the melody valve prior to that, but this was years ago. So I guess I'm a little curious just how you dealt, how did you perceive this as a setback, how you dealt with it, and what did it, because just what was going on through your mind at the time when they told you had to have another surgery, and what was the healing process like? How did you get through that?
Well, that was the rough part, having to find out that I have to have another open heart surgery. We were kind of hoping I could, since I had the pacemaker in there as well, we knew I'd have to get everything out. We were hoping it could be all done in one surgery, but unfortunately it had to be done in 3 stages. So I had my pacemaker explanted, I had the open heart surgery a week later, and then I got the ICD about 6 weeks after that. So it was a big pill to swallow, so to speak. Like you said, going along really healthy, doing well, and then hit with this. Emotionally, it was pretty tough. Just have to deal with that and go through that again. Open heart surgeries are not fun, especially when you've had multiple before that. Luckily, had a really good support system to help me through everything. Work family, real family, my spouse, in-laws. We were very fortunate to have a really good support system to help us get through that. Having, with my history, a lot of the congenital heart disease patients, setbacks happen, and so it's not a huge surprise, unfortunately. And I'm used to having, something happen every 5 years or so. I always joke around that I don't go 5 years without having some kind of intervention or something. So it's just something you gotta learn and deal with, and just kind of take it in stride and take it one day at a time. Although, it can really get you down if you think too much into it. But yeah, I was out of work for 6 months for with endocarditis last time. So it's definitely a huge change, not doing anything for 6 months, and relying on my wife for a lot of things, and changing her schedule and work schedule and everything. So it was a huge obstacle to get through it.
Thanks for sharing that, Shawn.
Oh yeah, no worries.
Yeah, thank you for sharing that. Just hearing your perspective about just that time clock that you have in your mind of every 5 years something's going to happen is something that we really need to be thinking about, and also in counseling patients going forward, and kind of you just appreciate that not only is this a medical issue, but there's also a mindset issue. And I also love the fact that you noted to your community. It sounds like you have a community of ACHD patients that you talk to and kind of work through these issues with. Hearing your perspective about your harrowing experience with endocarditis is really moving and informative for us clinicians. Also, note to self, always listen to the wife, especially related to health issues.
I still hate to admit that. She doesn't, 4 years later, she still doesn't let me let down.
Hey, be careful, Shawn. This is live, okay? So she's listening.
And recorded.
This is. Oh yeah, she knows. She knows I hate to admit that she was right about that one.
Well, we can thank her very much because
luckily I did listen. Yeah. It could turn out differently if I hadn't listened to it.
Exactly. So we're all very grateful here. Sometimes endocarditis is obvious, but sometimes it's insidious, and there's subtle signs and symptoms that luckily our patients can sometimes be attuned to. Our patients with ACHD are particularly vulnerable with devices and prosthetic material. Dr. Lin, how do you counsel your patients about prevention and detection of endocarditis?
Yeah, that's a really big challenge. You guys are probably very well aware that there's a lot of controversy these days about how we prevent endocarditis. Part of that is, at the end of the day, we don't have really good, solid data by which to drive our treatment regimen. So on this side of the pond, as you guys are well aware, according to the ACC/AHA guidelines for valve endocarditis prevention, anybody who has a prosthetic valve should get endocarditis prevention before they have dental procedures. And actually, the ACC/AHA guidelines are very prescriptive about what they actually talk about for dental procedures. It's not actually every dental procedure, so that's worth looking into to get into the details a little bit. Of course, anybody who's had endocarditis is also, of course, at risk of endocarditis again in the future, irrespective of whether or not they have prosthetic material. So that's also a consideration. The interesting thing is that on the other side of the pond, that at least in the UK, they're moving very much away from endocarditis prophylaxis, really sort of taking full frontal the idea that we don't necessarily have data to support what we do, even this 2 grams of amoxicillin or 500 azithromycin prior to dental procedures. And so I think it'll be really interesting for us eventually to see what happens in the UK versus what happens in the US. We'll actually see almost like a case control for whether or not endocarditis prophylaxis with antibiotics before dental procedures really does make a difference. Now, unfortunately, I would say Shawns' story is almost pathognomonic for how we sometimes see endocarditis present. So typically we'll have a very healthy individual, just like Shawn, who's having a normal life, all of a sudden just get knocked over. And sometimes it's insidious, sometimes it's a slow going 3, 4, 6 months, ultimately culminating in fulminant sepsis with heart failure, which is how some of our patients present. And in some of them, it's just this super fast process where, not only do they get endocarditis, but they also get stenosis, the pulmonary prosthesis, which gives them severe RV hypertension and then this syncopal episode and sometimes chest pain along with that RV hypertension. And it becomes almost a catastrophic event. So we do see a broad spectrum, but it is very classic to hear of Shawn's case. And it actually breaks my heart to hear it because I feel like I can really identify with it with many of our patients. I wish we had an answer. I think a lot of people, and let's just go ahead and put this out there, I think a lot of people like to point their finger at the melody valve and prosthesis as the culprit for endocarditis. I mean, I think that there's some interesting ideas there, and I think there's some interesting data there, but I just don't know that we know that yet. I think it'll be interesting as we get along further with all the other transcatheter prosthetic pulmonary valves that are coming along the line, from the Edwards Sapien balloon expandable prosthesis, as well as now the Harmony self-expanding prosthesis. And then, of course, pretty soon we're going to have the Altero self-expanding stent in which you can implant a Sapien prosthetic pulmonic valve. I think it'll be really interesting to find out whether or not we start to see echoes of the same risk of endocarditis from those prostheses. And then finally, the thing we really don't know is what's the risk in surgical pulmonary prosthesis. That's a problem. We just haven't done a great job as a community to really track that, because it may not be actually the melody valve itself, not sure. It may be just the pulmonic valve in general. We have always historically been concerned about right-sided valves being vulnerable. So it may be that the pulmonary valve is the worst of the 2 right-sided valves in terms of its vulnerability. And of course, I won't bore everybody with this too much, but there's also the way you do the transcatheter pulmonary valve implantation. So for the ballonatics, as Carol Warnes likes to call us, it turns out that how you leave the cath lab and whether or not you leave a gradient across the transcatheter pulmonary valve potentially has a lot of implications for your risk for endocarditis. And of course, early on in our experience with transcatheter pulmonary valve, we didn't know that you had to do a better job with pre-stenting the system before you implanted the melody valve. And so a lot of patients were left with the risk of fracture of the melody valve, which of course increases your gradient, which then of course also increases your potential risk for endocarditis. So a lot of nerdy data there, and a lot of hard things to sort of put together in small numbers. But I think hopefully what this means is as we put our heads together and as we do more studies on this area, we can do patients like Shawn a lot better good over time.
Thank you so much for that, Dr. Lin. I think we can keep talking about this hemodynamic implications of pulmonary valve in patients with the Cardiology Fellow, and also about the potential risk of endocarditis, the different techniques that we have in the future. But I was hoping to switch gears to the transition of care, that in patients like Shawn, in a prior conversation, Shawn, you mentioned that it was challenging to transition from pediatric to adult cardiology. and so I was wondering if you can elaborate a little bit further for the audience and for all of us here, what it looked like for you, and what can we do better with that regard.
Yeah, so I think, you know, like Dr. Lin can attest to this, adult congenital heart disease is relatively a new field. You know, we're surviving more and more now, which is great. It's just becoming a new field with everybody living longer. I think one of the things that we could do better as a healthcare community with the congenital heart population is start preparing adults, but also the patients too, at an early age, years in advance. They have to, before they transition, and let them know that, you know, they won't be able to see that particular doctor for the rest of their life, and just kind of get them, put a bug in their ear that they'll need to kind of start, you know, listening at these visits, taking part in them, answering some of those questions, and get them acquainted to going to doctors alone, or, you know, being a little bit more responsible for making appointments and, you know, taking care of their medications, appointments, going to the doctor alone, answering the questions, and instead of, you know, relying on mom and dad for forever. My parents are always really good. You know, they never missed a visit. They were with me at every visit. But I was also always very well aware of what I had, and was really into, you know, my congenital heart disease, and would research it, you know, growing up as a teenager and things like that. And knew I wanted to go into pediatric cardiology as a nurse. So I think that helped me, you know, look ahead to what I was going to get into as far as for seeing a provider. And where I went, luckily, I didn't have to switch organizations or facilities. The adult congenital doctor was actually board certified in pediatrics as well. So my transition wasn't really big for me, just because I knew that doctor already and it was the same facility. You know, my interventionalist was still his partner as well. So, and I knew in advance that, you know, eventually one day when I started getting late teens, early 20s, that I wasn't going to have to, you know, I wasn't going to see my doctor I'd been seeing for the last, you know, 12 or 15 years, that he would still be involved in my care, but that's not who I would see as my primary cardiologist. But that's what I'd always reach out to teenagers and everything, and just let them know that, you know, they need to start taking the lead in some of this stuff, and mom and dad won't always be there to hold their hand and to do things like that and make appointments and answer questions and be there for everything. And just to speak regarding the parents, that's a huge step for the parents as well, because like I said, my parents were always involved, and they still are, but it was a hard adjustment for them to not be the ones to make my appointment, not be the ones to, you know, be there with me for all my appointments. Instead, it was either myself and my wife. So it was a big adjustment for the parents as well. So I think preparing the parents too is also a huge factor that plays a role.
So Shawn, there's a question that came up online. For you, what do you think was sort of the critical moment for your transition, and what do you think you did that made it successful for you, in addition to the things that you've already mentioned, like being at the same institution?
Yeah, I think just knowing in advance, like I mentioned earlier, just knowing in advance that day is going to come at some point. And usually it's, like I said, it's you know, some people will transition at 18, some can see their pediatric cardiologist till 21 or so. But I think just knowing in advance that day is going to come, and preparing yourself slowly but surely is a huge help as well. Because it's always hard to, you know, when you've had a doctor for several years, they know you in and out, you know, it's hard to transition and to go to another doctor and have to build that trust all over again and things along those lines. So I think that was my biggest thing, is just knowing in advance that day was going to come. But it made it a lot easier that it was going to be, like I said, at the same facility, and not really have to switch whole haircare, you know, the whole healthcare team, and just my primary cardiologist.
And Shawn, you have the unique perspective of not just being a patient, but now you're a provider. So for those of us caring for patients like you, what could we do better with the transition?
I think like I said, kind of preparing these patients at an earlier age. I know some people will not know until it's kind of time, like, hey, you know, you're an adult now, so we have to transition you to an adult cardiologist or adult congenital cardiologist kind of last minute, and that usually doesn't go over well with patients and their families. So I think starting, like I said, you know, years before it actually has to happen, but also explaining the reasons why, and that, you know, switching from pediatrics to an adult congenital doctor is beneficial to them, because we all know, you know, adult congenitals, they can take care of the congenital heart disease or the structural heart disease, but also other issues, healthcare issues that those patients will also deal with just due to the normal part of aging that not necessarily has to involve their congenital heart disease, but could affect it at some point.
Thank you for that, Shawn. You know, transitioning from the pediatric to adult world is indeed a critical milestone for patients and families with congenital heart disease, and is especially fraught with discontinuity and heterogeneity, imposing undue emotional and financial stress on patients and their families. And Shawn, as you highlighted, you know, preparation is just so important, and counseling is just so important. And you just need to dip your toe into the water of learning about adult congenital heart disease to know that we will certainly see more and more of these patients, given the extraordinary gains in survival through childhood, such that there is now more adults living and even thriving with the congenital heart disease, more than children, such as, like, you know, you, Shawn, as a great testament to that, this growing population. Dr. Lin, building on Shawn's experiences, what is your experience with transitions of care and thoughts on how we can improve the process for our patients?
Yeah, if you'll allow me to editorialize for a little bit, one of the things that we're a little bit concerned about here within our program is that our program is the kind of program that will probably start to increase in the number across the country and probably across the world. What I mean by that is basically an adult congenital heart program that doesn't have a tie to a pediatric program. Why is that the case? Well, you can imagine at the end of the day, a lot of these adults are showing up in adult hospitals, right? Irrespective of whether or not they were instructed to show up in the adult hospital, irrespective of whether or not they should show up in an adult cardiologist's office, they're doing so. And so what that means is for us to meet the patients where they are, we really have to start to build more and more adult congenital heart programs in adult hospitals, irrespective of whether or not they're tied to a pediatric program. It would be ideal, but we don't necessarily have that option. And so not all of us have the options that Shawn has, and unfortunately I think we just have to adapt to that. Now, that said, I like your idea of dipping our toe in the pool as a parallel. And so one of the ways that we've been thinking about this, and full disclosure, we don't have our transition program fully off the ground yet, but we've been thinking very critically about how we're going to do that. But if you think about it this way, right, so if you're sitting in the pool, and the pool is the adult cardiac program, right, and the dry part of the beach is the pediatric cardiac program, and you really want to tell the pediatric patient who's going to transition what it's like to be in the pool. At the end of the day, you have to have somebody who comes from the pool to go and talk to the kid on the pediatric side, whether they're 12, 15, 18, 20, 25 years of age or otherwise. And so we think, and this is still in conversation, but hard conversations within our own center, that what we're going to have to do to be responsible about transition is we are going to have to reach out to the pediatric providers and to offer transition services within their programs. So in other words, we have to go and tell the kids what the pool is like, and to help them to begin to visualize what that's going to be like, just like the way Shawn knew was coming early on in his life and could start to prepare for that. We don't necessarily have to dictate exactly what that critical age of transition is. In other words, we don't have to dictate when the patient makes their transition physically to the adult program, but we do have to prepare them for that. And it sounds like in Shawn's situation, knowing that that was coming was a critical element in preparing for it and really making a good transition, irrespective of whether or not he was at the same center or otherwise. So I think what that means is adult programs, this is the gauntlet that's thrown down. We have to offer transition. And you see that. So in the ACHA accreditation requirements, we have to have transition programs. And so that's what's motivating us to make sure that we can do that. And of course, we will probably see other requirements down the line, such as Center of Excellence criteria from different payers, insurance companies, will probably also require transition programs for the adult congenital heart programs.
Yeah, thanks, Dr. Lin. And it sounds like what you're doing is being very deliberate about creating and fostering a transition program for the betterment of the patients that make their way to your doors. And I think it's just so important what you said about connecting a person's pediatric home with the adult practice home, so that way they can thrive in their personal home, in their personal lives. And I remember, Stephanie, when you and I, when we met with Shawn, this is an area that clearly was a source of a lot of grief, Shawn, for you, during the course of your own transition from pediatrics to adult. And so, it just really underscores how important this is, for the patient, for the family, and for really everything. The whole world is turned upside down. And, your perspective about, your pediatric team had been with you for over a decade, so I can just see how they were a source of support, and having to cut the cord from something like that and move to an unknown territory, I'm sure was very challenging and scary for a lot of people. But
yeah, I will say it's definitely a huge transition, and I still, like after my last surgery with endocarditis 4 years ago, I was lucky enough to be able to be in the pediatric ICU after surgery. But that my age was at the cutoff, and so now I know another surgery's coming. I'm not looking forward to it only because I won't have pediatric care after. I'll still miss it. So it's definitely a challenge to move on from that. So it's not simple to leave, even things like that, not just the clinic visits and follow-ups, but also post-op care and care, inpatient side too is another transition. You don't, go from pediatrics to adult world. And, when I was in there, I was like, asked for whatever it was at the time, and they didn't have it. And I was like, but pediatrics does. Can y'all just call them and get it?
I mean, what you're expressing right now is so real. You're showing us how much anxiety you have about being faced with adult cardiology teams, and that just, and as an adult cardiology team member, that just tells me that my team, we need to do better. We need to do better for you. We need to take away the cause of that anxiety. And that's really why we're here right now. That's why we have people like you to really show us the way, because it's not acceptable to any of us that you feel this way about the care that hopefully we can provide. We can clearly do better, and we need to figure out how. So thanks, Shawn.
No worries. And also, just one more thing about transition. I kind of made it sound like it was all on the healthcare team, but if there's any parents of congenital heart disease patients listening to this or watching, I also think it's parents play a huge role in that too, in preparing their own kids, because they know best how to prepare their kids for things along those lines. That's going to be a huge transition. So I also think parents play a huge role in that as well.
Yeah, thanks for mentioning that, Shawn. And for any parents that may be watching, if you have any questions for Shawn or the team, please definitely submit any questions you can ask live. You're part of this conversation. But you're taking it all in, Shawn. I just cannot imagine what it must have been like to go through everything that you did. We talked about the numerous setbacks, all the procedures, and of course you had a lot of successes. But your strength and resilience are just awe-inspiring. You've been through so much, but you let it empower you rather than bring you down. I do imagine that it takes a large village for you to come out to be who you are today. And so could you tell us what was it like growing up with congenital heart disease as a kid, and what were some of your major support systems growing up?
Well, obviously major support systems for me were my mom and dad. Like I said, they were really involved in my heart care, probably a little too overprotective, like most congenital heart disease patients are back then, and even now. Parents are very overprotective. I was always the heart kid. That's still how I'm introduced to a lot of people. Like, that's one of heart problems. So they were a little overprotective, but they were great, always involved in care, always there, didn't miss appointments. So they were a huge part of my supports, are really the support system. And obviously, some extended family as well, and friends were all, would come visit me in the hospital and things like that after surgeries, or take up for me at school, for things like that if I wasn't able to keep up or do things with them. So, those longtime friends were also, they knew me from the beginning and knew everything that I was going through and things like that. So it was definitely very valuable to keep going. Other than that, it was, childhood was pretty normal other than going to doctor's visits, having open heart surgeries, things like that quote unquote normal kids don't have to deal with. Recreationally and like sports, the only thing I really played on a team was baseball up until high school, I guess. And around high school, I wanted to play baseball there, but that's when doctors kind of like, yeah, maybe you shouldn't, push you too hard and really competitive and things along those lines. So that part was a little difficult, just, watching all my friends grew up playing soccer, which I never played, but I've always wanted to. But, that was one of the things that was hard to just watch all friends play that and things like that. So, but I would always be around them and at games or in practice or whatever. But so it was definitely tough. I mean, being born with heart disease kind of allows you to get accustomed to those things, not be able to do things. I always, seeing patients who are diagnosed with some kind of heart disease as a teenager or, had this whole normal life and then all of a sudden just hit a brick wall and can't do this or can't do that. I've always thought I've had it a little bit easier managing not being able to do things that my friends have done because I grew up doing it. So I guess that's sort of a silver lining. But, when you really think about it, it's still difficult to watch all your friends do things that you can't do. But, you find things that you can do and are you around them when they're doing it and try to get some kind of enjoyment, at least being with your friends while they're doing it. But, I was still able to, go outside, play with friends, do all the normal kid things other than organized sports.
Shawn,
I think... Oh, go ahead.
Sorry. When we chatted a few weeks ago, you told us a special story about ACHD camp. So I was hoping if you can share that with all of us, and also an opportunity to sort of explain to our audience that and the opportunity of having an ACHD camp for patients like yourself.
Yeah. So it's a kids' heart camp actually in Louisiana. Called Camp Boncoeur that it's been going on for 35 or 36 years now. I actually never went as a camper. I knew about it, but just never went for whatever reason. But after I became a nurse, I met up with the directors and all that. It's something to do with nursing. I forgot what it was, but I started volunteering as a nurse in 2012 there, and I know this will come up, and that's actually where I met my wife, who is a former camper and was also a counselor at the time, who was also born with congenital heart disease and has had surgery. So yeah, it's a great camp. It's like I said, it's for kids born with either congenital heart disease or acquired heart disease, and it just allows them to go to an overnight, week-long camp and do all the normal things that kids do on a normal basis, but in a safe environment with, nurses around, counselors who know about their heart disease, and it allows them to be normal kids and feel normal and be around other kids their age who, have a scar down their chest or have a device or haven't been able to do those things outside of this camp. So it's a great organization, and obviously met my wife there, so very sentimental place as well.
No, thank you, Shawn, for sharing that. It's a nice experience of inclusion as well, right? So yes, that kids see other people that are like them, with the same scars. Something that we don't think about, but for children growing up, it's important to have that. Dr. Lin, could you share some resources to create a little bit more of a support system for our patients that have ACHD?
Yeah. So it actually turns out that social media is a really huge opportunity for people to meet each other. And I think Facebook has a lot of different groups. In fact, on Facebook, there are numerous groups that are just specific to lesions. So for example, there's a tetralogy flow group, there's a D transposition group, there's an L transposition group, there's a general adult congenital heart disease group, et cetera, et cetera. But then of course, there are also organizations like the Adult Congenital Heart Association, there's the Zipper Sisters, there's Mended Little Heart, hearts and mended hearts, et cetera, that all advocate, but also provide a community for adults with congenital heart disease. And then, of course, within our organization, we, especially during the COVID pandemic, we've really looked to try to find a way to bring people together in a virtual environment, because my personal experience has been that I think the COVID pandemic has created even more isolation for our patients who already probably felt a little bit isolated socially to begin with. And so we worked really hard to try to create a peer support group through our social worker, Keisha Foxworth, so that way we can give people an opportunity to really meet other people that they otherwise wouldn't have met. So let me ask you this, Shawn. How many people, when you were growing up, did you know that also had congenital heart disease?
I knew of probably a handful or so. I mean, I had one guy in my school who we weren't really friendly, but we knew each other, and he actually has tetralogy as well, and went to the same hospital that I had, and my dad knew his dad and things like that. But it wasn't a lot. I mean, like I said, very few, maybe a handful or so. But and you see this too, I'm sure, is even adult congenitals, some of them don't know anybody that have congenital heart disease.
Yeah, and I think that's very isolating. Let me ask you this. Are you aware, there's a question on here that says, are there peer groups for adults like the camps that there are for CHD kids? Have you ever heard of something like that?
For a camp for adult congenitals?
Yeah. Not necessarily camp, but just peer groups of the same kind.
Not any that, except for the ones that you mentioned, like the Adult Congenital Heart Association, and I don't think there's any other that I know of. There's the Facebook support groups and all the ones you mentioned, but that would be fun.
You heard it here, folks.
I don't know of any others.
It's going to be Shawn Fontenot's Camp for Adults. Camp for Adults.
That's what needs to happen, is the Adult Congenital Heart Camp.
Yeah.
That would be interesting.
This would make a great Shark Tank pitch, Shawn. Yeah. You should get out there and raise some funds, because I think
I'll try to go to a Mavericks game and talk to Mark Cuban.
Thanks for sharing those resources, Dr. Lin. You really highlight such a healthy way to harness the power of social media and some great organizations that advocate and provide community for patients with ACHD. Shawn, going from pediatric to adult, going from a pediatric patient to an adult patient was not your only transition. You've literally gone from patient to caregiver. Indeed, you've got this amazingly inspirational and powerful story about how you became a nurse to take care of others with congenital heart disease. What drove you to do this, and how do your experiences with congenital heart disease help you care for your patients? And finally, what advice do you have for the rest of us to better care for patients with congenital heart disease?
Yeah, I mean, what drove me to go in this field is my experience, as a congenital heart disease and now an adult with congenital heart disease. I just always knew I wanted to do healthcare and something in pediatric cardiology. I used to tell my mom, which is my grandma, in case nobody knows that I either want to be the trash man so I could ride on the side of the truck, or a pediatric heart surgeon. And I didn't do either. So, but I did go into healthcare, obviously, and chose nursing. But yeah, my experiences as a patient and all the staff and doctors and nurses that I dealt with for my entire life are what drove me to go into healthcare, and especially pediatric cardiology. It's all I've done. It's all I'll ever do is pediatric cardiology. That's what I know. But it's more than a job, and it's a passion for me. Just dealing with patients like me, it gives them and also their parents something and somebody to look at and say, oh well, my kid has had heart surgery. Can they do anything in life? Can they have a normal life? And that's where I like to come in and be like, you can be like me. You can have a normal life. You can go to college. You can have a great career. You can get married. So it's really fulfilling to be in this field and be able to offer hope to patients and parents. And I've had several patients over the years that either said, oh, well, I want to be a nurse like you, or the parents will say something like that. And, look at Nurse Shawn, you can do those things too. And so it gives, like I said, the parents and the patients hope, which is really fulfilling. And, you know, like I said, I've had pretty much everything under the sun, congenital heart disease-wise, surgeries, you know, pacemakers, defibrillators. I mean, really the only thing I haven't had is the transplant, knock on wood. But it gives me an advantage over other nurses that can say, you know, getting a device or going through surgery is going to feel like this, but none of them have been through that. So it's really eye-opening for me to be able to explain and let them know that I've been through this. This is, you know, this is how I had it, you know, not necessarily that it's going to be the same for them. But I can actually attest to what living with the device is like, or going through open heart surgery during school, or, you know, just different life obstacles that they have to deal with on top of their congenital heart disease. So it definitely, you know, gives me a foot in the door, you know, having been through what they're going through or are going to go through.
Wow, Shawn, that was amazing. I think to have the experiences that you've had, all the challenges, and go through all of that, and turn it into something so pure and so positive, to be there and help other people, it really takes a special kind of person. And I just can't imagine the types of connection you make with your patients and how meaningful it is for them to have somebody look after them who's literally been through it. And I also think it's a testament to the kind of impact that when you were growing up, the people that took care of you, the impact that they had on you, because I mean, there's really no greater way for expressing gratitude and respect than to, you know, pursue that career track. So really, you know, kudos to you and congratulations for all the amazing work you're doing, taking care of people.
Well, thank you. I appreciate that. Funny story about that is when I started nursing, actually, when I worked in ICU, I worked with my very first nurse ever. You know, the day I was born and shipped to the ICU, she took care of me. I actually got to work with her, and also some other nurses who had been taking care of me for, you know, 20-something years. So that was like full circle. That was really, really cool to work with them. Like, hey, you took care of me, you know, 30 years ago. And actually, my first nurse remembered what I had somehow. So, oh yeah, you have tetralogy, or you have tetralogy. So wow. That was really fulfilling and special for me to be able to work at the same place that I was taken care of for so long.
That's just incredible. That really is. I can't imagine what it must have been like for that nurse to have you come run full circle like that.
Yeah, it was really, really neat. It's something special for sure.
You know, the joy you clearly have in taking care of other patients, I think it's shared by a lot of people that take care of people with adult congenital heart disease. They really are some of the most passionate and devoted of all of our colleagues. And I think because it's a life story, you're taking care of somebody with a whole life story. Like you have your own life story. So, Dr. Lin, I'd like to ask you, what makes your heart flutter about taking care of patients living with congenital heart disease?
Well, I joked about this earlier before we went online, but I got to tell you, thinking about the Cardiology Fellow patient who hasn't had that first pulmonic valve replacement makes me anxious, and that probably gives me atrial flutter, if you will. But no, I mean, I think, you know, it's so exciting and so gratifying to meet people like Shawn who have his level of resilience. I think it's really, frankly, inspiring. And honestly, you know, as an interventionalist, when I first started, it was really the cases, the complexity of the cases, sort of the coolness and the level of excitement and risk of the cases that really drove my excitement to come into work every day. But you know, I'm going into my 10th year in adult congenital heart disease, and at this point, it's not that anymore. You know, that kind of grows old after a while. It's really the patients. It's really the inspiration from the patients like Shawn that really drive me to get up early in the morning and come in early to work and get things rolling early on, because it's just such a joy to meet people like Shawn and just see the amazing things that they're doing and the amazing obstacles that they've passed through and come out stronger on the other side. It's just really an incredible experience. And the amazing thing is each individual story is more incredible than the next one. And actually, there's a couple questions that have come through the chat. So if you don't mind, I'm going to throw these out there. So one person asked, I think the challenge of transition is the heterogeneity of this group. How do you suggest we approach these teens that are in many different places? And I believe it trickles off to say circumstances. And then the second question was, do you have any advice for parents of tetralogy kids on how to prepare for adulthood? I don't know if Shawn, these are tough questions. I don't know if you have any suggestions on them.
I mean, the second one, I can probably attest to that, and that's just, I'm not a parent, so I've always, parents may like this or not like this, but I've always told my parents and just people in general that I am very grateful that I'm the patient and not the parent of a kid with congenital heart disease. I think my job is easier to be the patient. I just have to go there, go to the doctors, for surgeries, I'm put to sleep and, things, surgeries performed. I'm not the one that has to sit in a waiting room or go to the visits and worry about what they're going to tell me about my kid, or sit there for, 12 hours worrying about what's going on in the OR. So I think parents have it way more difficult than kids, in my personal opinion. And any advice on how to for them to be an adult, I think, is just to try to treat them as normal as possible and not let their heart disease dictate what they can and can't do, to a certain extent, obviously. But let them know that they can still do things. They can still go to college. They can get a job. They can have a good career. It's most of the time that will not limit what they can do professionally and personally. So I think treating them as normal as possible is a good thing, not using it as a crutch to say, oh, you can't do this because of this. My parents never, like I said, they were overprotective, but they never they never held me back with professional goals or anything like that, or going to school and things along those lines. They just kind of let me be, just, obviously made sure I got the care I needed, but pushed me to, do what I wanted and what I could in life.
Thanks, Shawn. And there's another question that's come up. Are there ongoing projects to raise awareness of these transitions amongst med students and trainees? Well, I think tonight's discussion is a great example, a live example, a real-life example of what transition looks like and how it can go well and what success can look like, as difficult as it can be. CardioNerds,
let me chime in as well.
Any thoughts?
Dr. Lin. So this is a clearly really important area, and Shawn, your experience highlights that at the best. And so it's CardioNerds, a podcast for creating the CHD series. We have a whole episode dedicated to transitions of care because it's such an important area, and our audience primarily spans from students through faculty. So I'm taking away a lot from this, and we'll definitely be adding some of that to that episode as well.
And I will say that I think much of the work that's been done at this point in time really comes from the pediatric realm. And I think it's really the American Academy of Pediatrics, through federal funding, that's really pushed this off the ground, the whole transition as a science. I think what that means is, again, like I said earlier, I think the adult side has to meet them halfway. And so what I think that means is it's incumbent upon us as adult providers, adult cardiologists, that we start to think about how we can participate in the science of transition and participate in the education and training of transition. So can't tell you what that looks like just yet, but I think all of you together and everybody listening to us today can help us to do some of this heavy lifting as we go forward.
All right, well, thank you, Shawn, for sharing your experience, and Dr. Lin and CardioNerds for this fantastic discussion. I hope that we were able to teach a little bit about the Cardiology Fellow, its repercussions, and also share the experience of Shawn as a survivor, and learn a little bit more about the opportunities that are out there for patients like Shawn.
And I want to say thank you again to the CardioNerds for joining us tonight and give us an opportunity to also be CardioNerds together, myself, Shawn, we're hopefully honorary wannabe CardioNerds tonight. It's been wonderful having you guys. Thank you so much, and thank you for having us, vice versa. And continue the conversation with all of us. You obviously know how to find us on Twitter and other social media accounts. If you have questions down the line, if you hear this on another day on the podcast or on video, please shoot us a message on Twitter and let's keep the conversation going. And again, I just want to remind everybody that tonight's event can be accessed for continuing education credit. We will put up these slides here in just a minute. Yep, right there, along with QR code. Go ahead and snap that QR code, and after you've finished completing the information, you can claim your CME credit and your continuing education credits. This is certified across multiple different societies for continuing education credit. Again, thanks all for helping us to kick off a wonderful 2021 Houston Methodist Adult Congenital Heart Awareness Week and help us keep the word going. Have a great night, everybody.
Thank you, everybody.